All right, let's paint a picture for you. Imagine this. It starts like any other typical Tuesday. You wake up and, maybe your throat's a little scratchy, your nose is a bit runny.
The usual stuff.
Exactly. You think, great, I caught a cold. You do the standard drill decongestants, a box of tissues, the works.
And you just expect it to go away in a week, 10 days max.
But imagine it doesn't.
Yeah.
Imagine that congestion. It never goes away.
And we're not just talking about a little sniffle here. We're talking about a blockage that feels like it's setting in like concrete.
Yeah. 3 months go by, 6 months, a year. And then the really terrifying part happens. You're making coffee one morning and you realize you can't actually smell the beans grinding. You step outside after it rains and that smell, gone. You panic, you check the gas stove, and it hits you. If there was a leak, you just wouldn't know.
It is a genuinely terrifying prospect, isn't it? I mean, losing a primary sense like that. And for millions of people, this isn't some hypothetical what if. This is their daily reality.
Today, we are diving deep into a condition that sounds like a mouthful, but is quietly ruining lives. It's called chronic rhinosinusitis with nasal polyps, or for short, CRSWNP.
CRWNP.
Yeah, and I want to be really clear here from the start, we are not just talking about a bad stuffy nose.
Not at all.
We're looking at research that suggests we're seeing a major shift in how medicine even understands chronic disease. We're moving from just looking at what the nose looks like.
Right, the physical symptoms.
To understanding the invisible cellular machinery that's actually driving all the chaos.
That is the absolute key shift. We're going from the what to the why. For decades, we treated the fire. Now we're finally looking for the arsonist.
I love that analogy. It's like the difference between just seeing smoke and knowing the exact chemical reaction causing the burn. So let's unpack this. We have sources from molecular science journals, clinical data. Let's start at the beginning. When does a bad cold cross that line into this chronic nightmare?
So the medical threshold is actually pretty precise. It's 12 weeks.
12 weeks.
If you have inflammation of the nose and your sinuses for at least 12 weeks, with symptoms like blockage, facial pain, loss of smell, that's step one. But step two is the smoking gun. We need objective evidence.
So you can't just say, I feel stuffy.
Exactly. We have to look inside. We need to see polyps on an endoscopy or see inflammation on a CT scan. That combination, the symptoms plus the visible evidence, that's CRSWNP.
And we should probably clear up a misconception right away because the word polyp kind of scares people. These aren't tumors, right?
No, absolutely not cancer. They're benign. Think of them like little teardrop-shaped growths, almost like peeled grapes that hang down from the sinus lining. They're just the result of extreme, uncontrolled inflammation. But the polyps themselves, they're just the tip of the iceberg.
They're the roadblock, sure, but the real story is what's happening to the patient. I was looking at the data we pulled on smell loss, and frankly, it just blew my mind. The source says that 9 out of 10 patients with uncontrolled CRSWNP have an altered sense of smell.
9 out of 10. It's the hallmark symptom. We call it anosmia or hyposmia. And if you look at patient surveys, something like 87.4% of them
87%.
identify the loss of smell as their most detrimental symptom.
That is just heartbreaking. Think about that. It's higher than the facial pain, the headaches, the constant runny nose. It's that disconnection from the world.
It affects everything. Taste is 80% smell, so food just tastes like cardboard.
Wow.
Safety is a big one. Can't smell smoke, can't smell spoiled food. But the biggest hit is on mental health. There's a profound isolation that comes with losing a sense. And the real frustration for patients has been that the standard treatments, like surgery, they often don't even fix the smell issue long term.
Which brings us right to the aha moment of this deep dive. Why were those old treatments failing? The sources talk about this huge conceptual shift from phenotype to endotype. This feels like the Rosetta Stone for this whole topic.
It absolutely is. This is the most critical concept to grasp, really, not just for sinuses, but for the future of medicine. Historically, doctors worked on phenotype, and phenotype is just what it looks like.
Okay.
You look up a patient's nose, you see polyps, you say, okay, you have the phenotype of nasal polyps.
So that's like walking into a mechanic's shop, pointing and just saying, that's a red car.
Precisely. But knowing it's a red car tells you nothing about what's under the hood. Is it a diesel? Is it electric? A hybrid? If you try to fix a Tesla by pouring diesel into it, you're going to have a really bad time.
And the patient is the car.
Right. The endotype is the engine. It's the specific molecular mechanism that's driving the disease.
Yeah.
We now know 2 patients can have the exact same phenotype noses full of polyps, but have completely different endotypes.
So for decades, we were treating all these red cars the same way, even though they had totally different engines.
Exactly. And that is why some people got better and, some people just kept suffering.
Yeah.
In the world of sinusitis, researchers have identified three main engines. We call them type 1, type 2, and type 3 inflammation.
Okay, let's look under the hood. Let's break down these engines. What's type 1?
Type 1 inflammation is your body's, let's say, standard defense mode against viruses and certain bacteria. It's driven by immune cells called Th1 cells and a chemical messenger, a cytokine, called interferon gamma. This is the engine that revs up when you get the flu.
Got it. Standard defense. What about type 3?
Type 3 is a bit different. It's driven by Th17 cells and neutrophils. Neutrophils are kind of the first responders of the immune system.
Okay.
They rush in to kill bacteria and fungi outside of cells. If you have a sinus infection with that thick yellow or green drainage, that's often the type 3 engine running hot.
So type 1 for viruses, type 3 for bacteria. But then we get to the villain of our story today, type 2.
Type 2 inflammation. This is the dominant engine in most Western patients with nasal polyps. Historically, this part of our immune system evolved to fight off parasites, specifically things like intestinal worms.
Wait, worms?
Yes, worms. In a survival situation, type 2 inflammation is designed to make your body incredibly hostile to a parasite. It triggers massive mucus production to flush it out, itching, coughing. It's a get-out-of-my-body response.
I'm guessing most people listening to this don't have intestinal worms.
Exactly. And that's the whole problem. In our modern hygienic world, this really powerful system, it gets bored, it gets confused. So it starts attacking harmless things, pollen, dust mites, pollution, even the good bacteria in our skin. It leads to allergies, asthma, and in this case, massive inflammation in the sinuses.
So talk to me about the chemistry. The sources are full of these codes, IL-4, IL-5, IL-13.
Right, those are the cytokines. Think of them as the generals of the type 2 army. They're the ones issuing the orders. Interleukin-5 or IL-5, that's the recruiter. It calls in the eosinophil.
And eosinophils are a type of white blood cell.
Yes. They're filled with these toxic granules designed to kill parasites. But when they swarm into your nasal tissue, they end up damaging your own body.
And what about IL-4 and IL-13?
They're like the architects of the damage. They tell the body to produce that thick, sticky mucus. They tell the tissue to remodel itself into polyps. And this is the key part. They actively destroy the olfactory epithelium.
The tissue that lets you smell.
The tissue that lets you smell. So you have that type 2 engine running, you are far, far more likely to lose your sense of smell.
Okay, this is where it gets really fascinating for me. The section on geography and the sources, I had to double check the dates. It talks about this huge difference between patients in the West and patients in Asia.
It is a genuine biological mystery. If you look at patients in, say, the US or Europe, over 80% of them have this type 2 eosinophilic inflammation. It's the dominant profile.
The worm-fighting profile.
Right. But traditionally, in countries like China or Japan, the profile was completely different. They had more non-type 2 inflammation, driven by those neutrophils we mentioned earlier.
So same symptoms, same polyps, but a completely different biological engine.
Correct. Which implied that for a long time, the disease was just fundamentally different depending on where you lived. But that story is changing fast. The data shows that as Asian countries have industrialized and, quote, westernized over the last 20 years, the prevalence of type 2 inflammation there is just skyrocketing.
That's wild. It's like we are terraforming our own biology.
We are. And it's not purely genetics. There's a pivotal study mentioned on second-generation Asians living in the United States. Their inflammatory profiles look totally different from their relatives in Asia. They look like Western profiles.
So you take someone with Asian genetics, put them in a Western environment, and their immune system literally shifts.
It seems so. It strongly suggests our environment, the pollution, our diet, antibiotic use, the lack of parasite exposure, is retraining our immune systems to become more type 2. We're basically making ourselves allergic to the modern world.
That is a pretty sobering thought. But let's bring it back to the patient. Knowing about type 2 is interesting, but if you're suffering, you just want to feel better. Why do the traditional treatments fail so often?
It goes right back to that engine analogy. Take antibiotics. If you have type 3 inflammation, the bacterial kind, something like doxycycline can work well.
Because it kills the bacteria.
Right. But if you have type 2 inflammation, which is sterile inflammation.
There are no bacteria to kill.
Precisely. You're just nuking your gut microbiome for absolutely no benefit. It explains why so many patients go through round after round of antibiotics with zero relief.
Okay, so antibiotics are out for type 2. What about steroids? That's the go-to, isn't it?
Corticosteroids are the heavy artillery. Sprays, pills, They are actually very good at suppressing type 2 inflammation. They shut those eosinophils down.
But you can't stay on high-dose steroids forever.
No, the cost is just too high. Bone density loss, weight gain, diabetes risk. It's not a sustainable long-term solution. It's a patch.
And then, of course, there's surgery, FESS, functional endoscopic sinus surgery, the old roto-rooter for the nose.
It's a crude way to put it, but yeah, it's accurate. The goal is to open up the sinuses, remove the polyps, and just clear the way. It helps breathing. But here's the problem. If that underlying immune engine, that type 2 machine, is still running,
The polyps just grow back.
like weeds in a garden. Exactly.
Yeah.
The recurrence rates in the data are startling. You're looking at 15 to 20% of patients needing another surgery within 5 years.
Oh.
And for patients with severe type 2 disease, the recurrence is even faster.
The source material mentions something called a reboot surgery. That sounds intense.
It is the nuclear option. It's a draft-through procedure. In really severe recurring cases, surgeons will go in and remove all of the sinus lining, strip it down to the bone. The idea is to force the body to heal with scar tissue that's hopefully less reactive. It's aggressive. And even with that, the data is clear. Surgical failure is statistically correlated with high type 2 inflammation. The biology just overpowers the surgery.
So, antibiotics don't work for type 2. Steroids are dangerous long-term. Surgery often fails. This sounds incredibly bleak, but this is where the script flips, right? This is where the biologics come in.
This is the revolution. We are now in the era of biologic therapies. And these are not blunt instruments like steroids. These are monoclonal antibodies. Think of them as precision-guided missiles designed to target specific parts of that type 2 inflammation chain.
Okay, let's name the contenders from the review. How do they work?
We have a few key players. There's omalizumab, which targets IgE. That's the main allergy antibody. Then you have mepolizumab and rislizumab. They both target IL-5. Remember IL-4?
The recruiter, the one that calls in all the eosinophil.
Exactly. These drugs basically intercept the recruitment letter. The eosinophils never get the call to show up.
But dupilumab seems to be the real star of the show in the data we have.
Dupilumab has shown really remarkable efficacy. It works a bit differently. Instead of just targeting one cytokine, it blocks the receptor for both IL-4 and IL-13.
So it's not shooting the messenger, it's putting a lock on the door so the generals can't even get into the command center.
That is a perfect way to visualize it. It stops the signals for mucus, for tissue remodeling, and for barrier destruction all at once.
And what kind of results are we actually seeing? Is this just hype or is it real?
Oh, it's very real. The clinical trials show dupilumab significantly reduces polyp size. But more importantly for the patient, this goes right back to our intro, it restores the sense of smell.
Really?
Yes. And one study showed it reduced the need for sinus surgery by 76%.
76%. That is massive. That's 3 out of 4 surgeries that just don't need to happen.
It is a complete paradigm shift. A big meta-analysis showed that dupilumab often outperforms the others in symptom reduction, and especially in quality of life improvement. It's tackling the root cause of the type 2 inflammation in a way we've just never been able to before.
So what's this mean for a patient? It sounds almost like a miracle cure.
It is life-changing, but I would hesitate to use the word cure. We have to be realistic. There is a caveat.
There always is.
These drugs are expensive. I mean, this is high-tech bioengineering. And the big question right now is, when do you stop taking them? The data suggests that if you stop the biologic, the polyps, and the symptoms, they often just come right back.
So it's maintenance therapy, like insulin for diabetes. You're managing the condition, not curing it.
Correct. You're managing the endotype. You're keeping that engine turned off. But you haven't removed the engine.
Still. For someone who hasn't smelled their kid's birthday cake in 5 years, or who lives in constant fear of a gas leak, that maintenance might be worth it.
Oh, absolutely. And it completely changes the conversation in the doctor's office. It's no longer just, let's schedule surgery. It's, let's figure out your profile.
And that's the real takeaway here for me. If you're listening and you or someone you know has these chronic sinus issues, that constant congestion, the loss of smell, that old one-size-fits-all approach is dead.
It is. We need to look at the blood work, the tissue. Do you have high eosinophils, high IgE? If so, you have type 2 CRSWNP, and we have specific tools for that.
Yeah.
If you have high neutrophils, you need a different toolbox entirely.
It's the difference between being treated as a statistic and being treated as an individual.
Which really raises this bigger question for the future of all medicine. We're seeing this in asthma, in eczema, and now here.
Yeah.
We're moving towards personalized medicine, where, a simple nasal swab analyzing your cytokines could create a treatment plan better than the CT scan ever could.
It's just amazing how much is hidden in the invisible chemistry of our bodies. We think of our nose as just a nose, but it's this whole battlefield of signals and cells.
And if you connect that back to the geography study, if our environment is driving this rise in type 2 inflammation, you have to wonder, what else is our modern lifestyle doing to our immune systems that we haven't even discovered yet?
Now that is something to think about. We went from a runny nose to global industrialization and a future of medicine in, what, less than 20 minutes?
It's never just a runny nose. The nose is the front door to the airway, and it tells us a lot about the health of the entire house.
I love that. Thank you for helping us unpack all of this. It's clear that for anyone suffering from this, knowledge is power, specifically knowledge of their endotype.
Knowing your type is the first step to feeling and smelling better.
Couldn't have said it better myself. Thanks for listening to this deep dive. Stay curious, check your engines, and we'll see you next time.